Welcome to Advanced Patient Care, the exclusive podcast series by Vance Thompson Vision. Our purpose is to keep you at the forefront of patient care through dynamic insights, practical clinic tips, and engaging expert discussions. Join us on a journey of continuous learning and professional growth as we delve into the latest advancements in ophthalmology and optometry. Our mission is clear: empower eye care providers with the knowledge and tools needed to deliver exceptional patient care. The Advanced Patient Care podcast is dedicated to elevating our craft, one episode at a time.
Hey, everybody. My name is Tanner Ferguson. I'm one of our cataract and refractive corneal glaucoma surgeons at our location in Sioux Falls and Sioux City. And I'm excited to be joined by Dr. Walton and Dr. Swan, and I'll let them introduce themselves.
Hi, I'm Kristen Walton, one of the optometrists at our location in Omaha.
Awesome. My name is Russell Swan. I'm one of our surgeons out in Montana at our Billings and Bozeman. And I missed the memo. It's cataract awareness, but I thought it was chalazion awareness. So I apologize today. You got to deal with me and my pirate eye. Happy to be
And
here.
we might even get a sneak peek of some of Russell's beautiful children. He's solo dad mode today. So that's a bonus content for everybody. And this podcast, we'll be talking about, kind of an update on cataracts. This month is Cataract Awareness Month, which is the number one cause of preventable blindness across the globe. So it still carries a meaningful burden for patients across the globe, particularly in those in developing countries. But we'll talk about, how to communicate with patients, managing expectations after surgery, and some of the more latest advancements. And maybe we can share some personal insights on how we approach, these conversations, what we would put in our own eyes, family members, things like that. But we'll start by talking about how do we communicate these lens options, because the lens landscape has changed tremendously over the last 5 years and continues to change. And so the options are constantly evolving. And, I think it's important to kind of simplify what the options are based on the visual goals of the patient. So Kristen, maybe we'll start with you. And I think we can all kind of share how we have this conversation with patients. I think that'd be helpful because I think everybody does it a little bit differently. Maybe we can start with you and you can kind of share how you approach this.
Yeah. So obviously our technicians do a thorough workup, getting pictures of the front of the eye, back of the eye. I review all of those before I go into the room. And then I just sit down with the patient and go over pretty much all the information that's given to me in the chart from our technicians, just like starting to get an idea of what this patient does, like in their occupation or what they do for recreation. And then also just like, do they wear contacts? Do they wear multifocal contacts? Do they wear their glasses all the time? Do they take them off to read? Because that starts me thinking on, okay, what options are going to be best available or suited for this patient to kind of maintain what they do, or are they looking for something different? And then I go through the exam, make sure everything is healthy. And then if the eye is pristine, other than the cataracts, like I said, there are a lot of different options in the cataract space at this point in time. So it can seem very overwhelming to just start listing, hey, healthy eye, you can do whatever you want. So then it comes down to, okay, you like to golf and you want to see the best distance vision possible. What lenses are going to provide the best contrast sensitivity? And are you okay giving up a little bit of reading? So again, breaking it down to, first of all, do you love your glasses? Do you hate your glasses? Some people love them because, again, we talk about oculoplastics and everybody's worried about the bags under their eyes. Sometimes it hides things for people and they love it, or people won't recognize them without glasses. But otherwise people come in and they're saying, no, I don't want to deal with glasses. And then we start talking about multifocality or a little bit of mini monovision, those types of things.
Yeah, I think that's great. Russell, you want to go and then I'll maybe share how I approach things.
Yeah. And I think Kristen laid it out really nicely. And I think, for me, one of the things I've tried to do as I'm communicating with patients about it is trying to keep things as simple as possible for them. And I think taking in all the factors that Kristen mentioned, which is super helpful. And usually my conversation with patients once we get to that point is, hey, my job as a doctor, as a surgeon and your primary eye care doctor, our job is to tell you when you have a cataract, and your job is to decide when it bothers you enough. And if it bothers you, then really the next question is, do you want to do a lot with glasses or a lot without glasses? And I like to remind people, their natural lens, which has now become cloudy and what we call a cataract, when they were younger, it kind of had two functions. It provided clarity of vision and it provided flexibility or range of vision. It was kind of provided them with their reading range. And most times when we're doing cataract surgery, it's someone in their 60s. And so they've, experienced presbyopia in their 40s. And so I like to talk to them, when we do surgery, we can either just replace the cataract and work on the clarity aspect, or we can work on the clarity and giving some of that flexibility and range of vision back. And then let them kind of guide the discussion from that perspective. And I think the big thing also that I like to remember, because, we do a lot of surgery, we talk with a lot of patients, but for our patients, it's the first time they'll ever have cataract surgery. And so also really reminding them, average age for cataract surgery in the US is about 65. And our friendly actuary friends would tell us someone who's lived to be 65 in the US will live to be on average 85 years. So they're making a 20-year decision about how they want to use their eyes for the rest of their life. And just remind them to think about that. And also let them know, like, it doesn't necessarily have to be a decision they need to make that day in the chair. We want them to have the information so that they can make the best informed decision for their eyes.
Yeah, I think that's great. I think you guys both brought up some points that I try and or I think about in every visit I have with a patient. First being, there's a lot of information we can give to patients, and that's why we give them information before they come in, while they're here, and then oftentimes we arm them with additional information once they leave, because I think it's easy for them to be overwhelmed, especially you start listing out, you can do this, you can do that, you can do this. Then they just are like, I don't know what to do. I'm not even sure if I want to have surgery anymore. And I think simplifying it, as Russell mentioned, and not listing out information, things like that, trying to guide the conversation, I think is super helpful. One thing you mentioned, Russell, I think is I mentioned in every discussion with patients is, you're kind of making a decision that's going to dictate how you use your eyes for the rest of your life. And I kind of liken it, and I think sometimes people have this perception or idea that they can choose this lens, and then 5 years down the road, they can choose a different lens. And then 5 years after that, they can choose a different lens. And I sometimes use the iPhone analogy of, it's not like getting an iPhone 10, and then 5 years down the road, you can get an iPhone 15. And then 5 years later, you can upgrade from there. So I like to remind them that this is a decision. And I like to emphasize the importance of it, that this is a decision of how you're going to use your eyes for the rest of your life. And I also remind them that the structured eye that changes as you get older for most people is your lens, but we remove that part of your eye and replace it with a fixed lens that we would not expect to change as you get older. And so that's why it represents a choice of how you want to use your eyes going forward. And I think the other thing you mentioned, Russell, was not kind of forcing them into a decision on the day of the consultation. I think, like we've already mentioned a couple times, this is a big day, a lot of education, a lot of information, and it's easier for them to become overwhelmed. And I think as soon as you say to them, sometimes I think you can kind of in the room sense somebody, feeling overwhelmed or kind of anxious about the decision. As soon as you say, you know what, you don't have to make a decision today, go home, talk about it with your family, spouse. I think you kind of see them kind of their shoulders ease and they feel better about the information or the consultation. And sometimes they even feel like they have more of a clearer mind. And then the last thing I do is I'll often make a recommendation based on the things they've shared with me or they shared with our technician. Like, for example, they have a history of success with monovision contacts, or they had previously had monovision LASIK. I might steer the conversation towards, light adjustable lens technology. If they're a +2 hyperope, they hate reading glasses, I'm probably going to talk to them about multifocality, assuming they have a very healthy eye. And so I think offering them a recommendation, and then if you offer the recommendation, they kind of voice some aversion to that option, then we'll talk about alternatives. But I like to kind of offer a recommendation. Any other thoughts on that, guys?
I think a recommendation is key because they're coming to us to help guide that conversation. And, a lot of them are saying, hey, you're the doctor. I want to know what your true thoughts are and what's best for my eye. And I think that also helps kind of quell any reservations or hesitations in picking a lens when they know that somebody that is specialized in doing this is telling them, hey, this is a good idea.
Yeah, I think it's true. And there's good data to support it.
Yes.
So there was a survey from one of the lens companies that showed I think greater than 90% of patients want to get a recommendation from their doctor on what lens to choose. And I think only a third actually get a recommendation from their doctor. So I think patients are definitely seeking that. All right, let's maybe move on to, how do we talk to patients about, realistic outcomes, expectations, and kind of let's walk through that maybe aspect of the conversation. Russell, we can start with you on this one.
Yeah, I think so. I think once you've made a decision on what lens it is, that's really going to help guide it, the conversation, because again, a lot of the managing expectations is really built around, what lens technology are we using? What are the goals of that technology? What are the pluses and minuses and side effects? And so I think, from a simple standpoint of, hey, a patient chooses a basic lens and they have a diopter and a half of astigmatism that's, with the rule, and they've, had very minimal correction previously because maybe the lens it's some lenticular astigmatism that was neutralizing it. Making sure they know when they're selecting a basic lens, hey, you're probably going to be in glasses for all things, distance and up close, even though for a lot of your life you haven't been. A very simple thing of managing expectations. I think also then on the flip side is, again, it's just really educating people on the front end so that there's no surprises. So someone's choosing a light adjustable lens, making sure they know for, about 2 months, we're going to be hanging out a lot. We're going to be making those adjustments. They're going to be wearing glasses when they're outside. Someone with multifocality that's going down that route that's maybe never experienced in a contact lens, making sure that they understand, hey, this is a visual journey. This is kind of what we call a 3-step process plus time. So maybe that's a 4-step process, but it's cataract surgery. It's a possible YAG. It's a possible laser fine tune. And then it's a period of 6 to 12 months of neuroadaptation. And so the first 6 months are really around, refining the surgical outcome, reducing refractive error, making sure there's no dryness. And then the next 6 months are around neuroadaptation and allowing the brain to get to a great spot. And I think so long as you're having that conversation on the front end, patients know it going in, they're not surprised by it. It is their expectation. So it's been managed before. It's when they're surprised by something or they don't see it or they don't expect it where it's maybe a little bit harder. And I will say, the one thing that's really been fun, the last several months in a bunch of our offices, we've been able to use a virtual reality technology called Greenman. For the first time, we can actually show a patient, put them in a pair of virtual reality goggles and let them experience a home environment and let them experience what nighttime driving looks like with a monofocal or a toric or a multifocal or extended depth of focus or monovision, and demonstrate that for them so that they can kind of experience that and know on the front end. Because before we were kind of using, word expressions or 2D pictures on a computer screen or a printout, but to actually, sit in a world, reach out, be able to pick up a book and understand, okay, where's my near point of accommodation with these different lens technologies has been a really fun thing for kind of helping people experience the educational process and experience kind of what to expect on the front end.
Yeah,
I will echo those comments you shared, Russell, on the VR simulator. I was going to bring that up as well. This has been, I think, and honestly, it makes the expectations conversation after surgery so much easier that they themselves have simulated these different options. And I think, some people will say, well, can you use like a video simulator that they already have? And the nice thing about this VR simulator, this wearable headset, is that's immersive. So you can pick things up inside these, like a darkly lit or a well-lit room, and kind of have a good understanding. Okay, I can see the book here, I can't see the book here, while also looking across the room. And so the immersive environment that you can experience both inside and outside, both light and dark, I think is super helpful for kind of simulating what to expect after surgery. You touched on a lot of great things there, and I think most importantly, I think it kind of is, the conversation is very much dictated by the lens option. So the conversation about expectations with a light adjustable lens is very, very different than the expectations with a monofocal or a multifocal lens. And when I usually bring up, potential downsides, such as halos, neuroadaptation, things like that, it's usually after I offer the recommendation. So I'll say something like, I think this lens would be great for you based on your history of monovision contact lens wear or your history of hyperopic and wanting to get a reading glasses. talk about the benefits, and then I'll say, there's a couple downsides to this lens. And I'll usually talk about cost, and then I'll talk about, some people experience halos around point sources of light, and some glare at night, and then talk about the process of neuroadaptation. And then that's also where I'll talk about, when we do surgery, we take measurements of your eye, take those measurements, plug it into a formula. Those formulas are great, but they're not perfect. And so sometimes we're left over with some residual prescription. But that's why we offer free, LASIK enhancement within that package of that lens package that you paid for. And we know based on research that doing an enhancement is important, or offering enhancement is important because it optimizes the performance of the lens that we put inside your eye. And so I think bringing up enhancement, I think, is really important when we talk about multifocal lenses or torics or extended depth of focus. But that's kind of how I kind of bring up the side effects and expectations. The other thing I'll note is if I think something is important for the patient to hear, I'll find a way to intentionally say it twice. So say it a first time and then, talk about it and then intentionally bring it back up, to heighten the possibility that they, it registers with them, because I'll bring up more data, but there's good studies that show that patients forget between 40 to, I think, 80% of what they hear during a visit to their doctor. And when they do remember, they often misremember. So they remember what they heard incorrectly. And so that's why I think that's why we believe in, pre-educating a patient with information before the visit, obviously during the visit, and then oftentimes even after the visit, and then continually through the process. You approach things any different?
The happiest patients are the most educated patients ahead of time. No matter what, expectations they have for like glasses or no glasses, if they know what's coming, and that, like you guys said a couple times, that there are no surprises, they're ultimately going to be happy with what they selected to go with. So I work really hard at making sure and reiterating points of, hey, just making sure, like, if they're a -250 myope and we're going to do standard lenses and we're going to target distance, that you understand that glasses are not going to, you're not going to be able to take them off anymore and read. And as long as they acknowledge that and they accept that, then aftercare is a lot easier, again, with no surprises.
That's great. One thing I think is important to bring up that's kind of unique to the light adjustable lens, and because this is the podcast for doctors, I think one thing that's important to keep in mind is sometimes pre-adjustment. So between that, post-op day 1 and 1 month visit, when somebody is implanted light adjustable lens, the patient's near vision is not what they'd expect, even though we talked about this blended vision aspect. And I think everybody approaches things differently a little bit, but I think most people tend to overshoot distance, knowing that they want to bring adjust from distance to near. And so I think it's an important reminder for those listening to the podcast that when we do the LAL, before we do adjustments, the patients may need some readers for up close, and likely will actually. But when we like to adjust from distance to near, and that's when during the adjustment process is when we'll fine tune their near, and even oftentimes, fine tune their distance if they have some astigmatism. So let's talk about new technologies. It's kind of a fun topic because things are constantly changing, and we are very, very lucky and fortunate to be involved with, or have been involved with a lot of the studies leading to, we're involved with a lot of the studies leading to approval of some of the lenses we now have available to us today. So maybe we'll start with, kind of the trifocal lens category. So the first option in this category was called the Panoptix. And then there was another option from J&J called the Synergy, and now there's the Odyssey. And then now there's another lens option called the Envy from Bausch & Lomb. And I think down the road, we're going to get a lens option from Zeiss, and then potentially another kind of competing option from another company. Chris, I don't know if you want to share maybe any experiences you had, if you guys have tried some of these different options or anything you're excited about.
I'm excited to see, what Panoptix has in the pipeline. A little bit potentially more near vision with a little bit less halos at nighttime. I'm kind of.
Are you talking about that Panoptix Pro?
Panoptix Pro. I think we implanted one I haven't heard anything about follow-up as far as how he's doing, but I mean, patient and us, of course, we're very excited to be able to do that for him. So I'm excited to see what that does. Little experience with the NV lenses. Better halo profile at nighttime, maybe not quite as much near. But again, just managing those expectations with patients and, pluses and minuses to what works best for them. We've done a little bit with the clear view. I think that does well for some
Oh
patients.
yeah, that's a great lens to bring up.
Yeah, Clearview has been doing really well. We were part of that study and did some outside of the study as well. Again, patients that are saying, hey, I really want that multifocality and I don't want to deal with any halos. I would agree that one was easier for patients to accept as far as what that dysphotopsia at night looks like.
Yeah, and I think important to bring up the Clearview, I would agree, has performed way better than I think people would expected based on the design of it. It's technically called a segmented bifocal. And so it has a distance segment and a near segment, but it very much behaves like a continuous range of vision lens. And I think a lot of our surgeons have been very, very happy with how that lens has performed. Kind of like you said, great multifocality, continuous range of vision, and maybe less glare and halos than the more traditional diffractive optic lenses. The other lens I would bring up that I've had some success with is the Odyssey. It's kind of the J&J Johnson & Johnson trifocal. Another thing caveat I'll say is, the lens technologies is becoming so great that it's kind of difficult to kind of compare these lenses because they all perform so well, great range of vision. But I think it's also good because, these lenses are constantly trying to evolve. That's why we have now the PanOptix Pro. And so they're constantly trying to advance the technology. But coming back to the Odyssey, this lens very much, behaves like a trifocal lens, great distance, intermediate, and near. And I found that they maybe get a little bit better image quality at distance than some of the other trifocals. I feel like more patients see uncorrected 2015 in my experience, but maybe don't get the same level of near as you would with the PanOptix. So I've used it in primarily post or previous hyperopes who aren't having that expectation for great near like a previous myope, but I've been very happy with visual quality in that lens. And I can't really totally speak to the Envy. I think I put in one. Patient was happy. But the PanOptix Pro, I have put in a few, and so far so good. So I'm excited where things are at, and I'm excited where things are going in the kind of multifocal lens space. Russell, you have any additional insights to share there?
No, I think the big thing I would just say is like it's awesome to have options. And as the old man on the panel, I grew up in the time of just having bifocals and mixing and matching a near bifocal and an intermediate bifocal and not having toric correction. And so to have trifocality, to have the ability to have toric correction in many of those lens choices just allows us to be able to give patients even better outcomes right from the beginning. And it's been a really nice change for us.
Russell, when you were a fellow, did you have the Symphony?
A long time ago in a galaxy far, far away. Yes, we did have the Symphony, which was the first kind of extended depth of focus lens. Had a little more glare and starburst profile for nighttime vision quality compared to like a Vivity, which is another extended depth of focus lens that we more commonly use now, compared to an Apthera, which is a pinhole extended depth of focus lens, which we primarily use now more actually off-label and in irregular cornea. So yeah, we didn't have very many options. We had the traditional bifocals and first generation extended depth of focus lenses at the time.
Yeah, it's pretty amazing how much things have changed in even half a decade. I think looking from your fellowship to my fellowship year, EDOFs, light adjustable, Apthera, and maybe quickly just on the EDOF landscape. So as you mentioned, the Symphony was the first option, and then the Vivity, which had a little bit different design. They called it non-diffractive wavefront shaping. And like Russell said, I think it does provide a much better visual disturbance profile. Now we're going to get more options in this space. I think Bausch and Lomb has a lens option coming in this category. And then Johnson & Johnson has a option called the PureC, so PUREC, that was studied here in the US, is currently being used outside the US. And I think it's trying to compete with Vivity in that it's supposed to give you, similarly good distance intermediate and a better visual disturbance profile. What are lens options? We can talk about light adjustable lenses. So, this has been around for, I think technically 6 + 6 years, but The second generation option with active shield has been around since 2021. And I think the thing that's maybe changed with LAL since it's come out is we've just gotten better at patient selection, maybe the adjustment process, and counseling patients on the technology. I don't think the technology has really considerably changed. But I've been really happy with this lens. I find it to be a great option in patients who are previous LASIK, previous RK in the right patient, previous monovision contact lens wears. And then I also like it. It's kind of my go-to lens if somebody has any concomitant pathology. So somebody has like a subtle ERM. I'm not a big fan of, extended depth of focus or diffractive optics in those patients. If somebody has some, more mild to moderate glaucoma, then I usually kind of steer that way as well because of the forgiving optical quality versus the diffractive optic lens. But I don't know if you guys have any insight to share on LAL that's different than mine.
I would just share. Oh, Kristen, you go for it first.
I know, a quick, we get a lot of questions about, like when patients should wear the glasses, am I okay to
Oh, good
dial
point.
in, do BIO exam, all of those things within the exam room, totally fine. No worries on that. We're getting a bit more relaxed with the glasses. We used to have to wear them all the time. And then again, in addition with the active shield, we only require them to wear them outside. And so that's also easier for patients to accept, so they don't have to be sporting those LAL glasses all the time.
Mm-hmm. Yeah, and I think the only thing I was going to add, Tanner, just from like a personal perspective, I always want a question patients always ask is like, what would you do if, what lens would you have if it was your own? And going to that point of recommendation, for my own eye, previous -6 PRK now, but previous myope, like an LAL is the lens of choice on the current market that I would use for my eye. I have a more aberrated cornea, going to have a little more likelihood of a refractive surprise. And so a light adjustable lens would be really beautiful. If I had a naive cornea and beautiful pathology, I'd choose one of our beautiful diffractive trifocal lenses and preserve some of that range of vision. But to your point, again, each technology, we used to not have as many choices. Now we have all of these beautiful technologies and we can really fit the technology to a patient's eye and to their desires and visual outcomes, which is great. What would you guys have for your own eye?
Russell, you got to take care of that chalazion before you get measurements for your cataract surgery.
I induced about a diopter of astigmatism in my eye over 2 days. It's pretty amazing. So,
I am also a previous myopic LASIK, and I think I'm very sensitive to distance vision being good. So I probably would similarly do LAL. But to share some personal experience, I put paint optics in my mom's eyes. She's incredibly happy. And then I put a light adjustable lens in one of my dad's eyes. My dad's actually a unique patient. He had LASIK in just one eye. He was like a -1 naturally. So did LASIK in just one eye. And then his first eye was done by Dr. Berdahl during the bifocal lens era when Russell was a fellow. And he has I believe a Johnson & Johnson, like one of the low ads, maybe ZL Boo. Is that right, Russell? ZL Boo?
Yeah. Yep.
And then he has a light adjustable lens in his dominant eye, which he had LASIK in. So he's kind of a unicorn patient in some ways, but very happy.
I'm a baby hyperope, so just always accommodating. My distance vision has always been amazing. So I'm with you guys in LAL. I probably would not want to lose any of my contrast sensitivity to get the multifocality. So probably an LAL girl. I did recommend my father-in-law have LAL, and he actually had surgery with Dr. Greenwood up in Fargo, and he's loving it. So yeah.
That's cool. So obviously we talked about a lot of information, and we could talk about this for hours because cataract surgery is such a big topic. And that's why we've put together a lot of, kind of cheat sheets, updated brochures, information online that patients can be directed to. And, as our optometric community, if you need more additional information from us, we're always happy to offer that to you, whether it's a phone call, text, or directing you to some of these additional information sheets that we have, whether it's the cheat sheet, things like that. We often will give patients some of these things when they leave because oftentimes they are undecided and we like to arm them with additional information. But if you feel like you aren't getting the information you need from us, please let us know. And that will, I think, recap our episode. Thanks, Chris, and thanks, Russell. Great job.
Awesome. Thanks, Tanner.
Thank you for tuning in to Advanced Patient Care, the exclusive podcast by Vance Thompson Vision. Want to learn more? Schedule a personalized mini fellowship at one of our clinics where you can gain hands-on experience and real-world applications tailored to your practice. For more resources and information, visit vancethompsonvision.com/OD. Let's continue advancing patient care together, one episode, one innovation, and one patient at a time.